And so I'm going to come from a medical perspective. I'm a physician. I take care of patients. I'm boarded in addiction medicine, but also in infectious diseases, so I'm bringing some of that information together with this. I'd like to thank a number of people who helped contribute to this presentation here at UM, Howie and Ezra and Adiba, Jeff from Yale, Steve Shoptal from UCLA, who's done a lot of work with behavioral interventions for amphetamine using MSM, and George Woody, who's done some work not with MSM, but with treating amphetamine. So just to put the stage, first and foremost, we are at one of the biggest epicenters for amphetamine use. And while we were talking about chemsex, amphetamine is a big player in all of this. GHB, you can overdose, there's all of these sorts of things. There's a number of cocktails. We're going to talk a little bit about why that is. It's the reward system. It's not just a specific drug. It is really almost anything that you put into your mouth that changes the system so that you feel rewarded. But we are in the epicenter, so I'm going to show some data from the US because these are the two places where we're seeing it really quite concentrated. But it happens all over the world because you see these trade routes that happen elsewhere where there is a transfer of amphetamines. They're cheap, they're easy to make, you can make them in your bathtub. It's really very easy to do. And you can imagine if you're not making it well, you can have some incipients that cause some other consequences like Parkinson's disease and stuff like that. So lots of other complications with this. For those of you who got up and had breakfast this morning, many of you probably had nausea lamont. Well, why did you do that? It gave you great pleasure. You got up in the morning, you got a reward, it felt great, and you went about your day. And of course, eating disorders are really part of this addiction sort of spectrum. And so we get a lot of pleasure. We get a lot of pleasure from some things. We talk about a runner's high. We can have alcohol, we can have drugs, we can have a cigarette, we can have sex. They're all things that give us reward. They give us pleasure. But the question is that there are different kinds of things that have different levels of rewards. And it is the case that things like amphetamine are much more rewarding. And the way that they do that is they dump dopamine from the presynaptic terminal in the brain, so this is a brain disease, and dopamine is the pleasure drug. It's what makes you feel good. It's that moment that you have either when you use a drug, you take a drink of alcohol, you have really good sex. This is the pleasure stuff that's happening with this. But there are different kinds of rewards. And so part of our treatment is actually about finding things that may be less rewarding, but sustainable. So let's talk a little bit about how we get here as a brain disease. There are a number of people, we say, well, why does this person use? They're from a nice family. The issue is there are some biological mechanisms for people who are predisposed, but you may come from one of these predisposing families like my own, and I just happen to not go down that pathway because there are other things like the environment that contribute to this. And they're synergistic and they come together oftentimes in people, places, and things, so that there is one, the initiation phase, where you have that introduction of the drug, that aha moment, I feel so good, and you try to re-achieve that again. Like, if you go down a roller coaster and it feels good, you do it again, you go buy a second ticket. And this is what often happens. It changes, it alters the brain, it releases dopamine, and in the case of methamphetamine, it depletes the dopamine so the brain cells actually die. All right, so there are consequences, and then ultimately it can move towards a more problematic situation called addiction. This is where the root of it all is. It's that happy drug dopamine that is released. And so as I begin to think about some of the targets and why we sort of think about treatments for this, we're going to sort of focus a little bit on dopamine, but I will tell you the bottom line is we have modest, at best, behavioral interventions and really no medication treatment that is truly effective, and I'm going to walk you through some of those trials. So I'll give you a sense of what we've got and where we need to go. This is a brain disease. There's a certain part of the brain that contributes to this pleasure pathway, whether it's the runner's high or whether it's the methamphetamine. We know that there are certain areas that are differentially affected so that the pathway is not completely the same within the brain. And we see that certain kinds of drugs and activities occur in the brain. But we can look in the brain and do functional MRI so we can see the biological basis of this that occurs, and where you see these are, the red marking is dopamine, and we want lots of good healthy dopamine. That's a healthy brain. So on the left-hand side, we see healthy controls, and we look at people who have an underlying substance use disorder, whether it's cocaine, methamphetamine, which are stimulants, alcohol, and heroin, and what you see is it happens and it gets depleted. And so you can imagine that, let's say for instance, if it's Saturday night and you go and you have a lot of methamphetamine, you dump all of the happy drug into your postsynaptic terminal, and then all of a sudden your body's got to extract it. It takes it all away, but there's nothing left in the presynaptic terminal. You're all of a sudden at the opposite. There's no pleasure. We call it Suicide Tuesday. Happens about 3 days afterwards. But people sort of mitigate this whenever they're out there. They say, oh, we'll do this, and then we take a little cocktail, we take a little bit of Viagra to have a good time tonight. 2 days later, we take a little bit of a serotonin reuptake inhibitor, so we block the reuptake of serotonin and all these other sorts of things, and we sort of self-treat, if you will. And so that's part of what ends up happening in the real world and why other substances come into chemsex polysubstance use problems. Now there are clinical definitions that are sort of associated with substance use disorders. There's a handful of things that you can look at. By the way, I've got a ton of slides, so I'm going to blow through them, but you can have access to all of them. And you sort of have to meet a certain amount of criteria. And what has happened over time is we sort of have recognized, you know, there was the time in the 80s in the US when any drug use was demonized and it was terrible. But the real truth of the matter is that there is a spectrum and a range of severity. And there are what I call the person who doesn't use or the person who uses occasionally. They're not really getting into trouble. They're having a good time. How many people have banged back a cocktail and had a pretty good time and it's not that big of a deal? There's no sort of social or individual harms that come from that. We all do lots of things that are potentially harmful. But then as the pattern begins to increase, there may become some problems with this, all right? And so it becomes what we call harmful substance use at that time. And then at the far end of the spectrum, we have this mild to moderate substance use disorder, and it can become severe. Now, what we often talk about is the highest level of severity. Carol was talking about in their Hornet survey. These were the people with the highest levels of addiction. So unfortunately, what happens with our policies and our treatment, we sort of put it all together in one group. You're a drug user or you're not a drug user, when the reality is that there's a real spectrum that happens with that. And the ones who are in the most trouble are the ones who need the services most. But I will say, as we start to get to some of these clinical trials, we do these clinical trials in the same way that we do cancer trials. We take patients with stage 4 disease, metastatic disease, the worst, and we try to apply a really ineffective therapy to it, and it just doesn't work to the same extent. So I will sort of challenge you all to think that maybe perhaps we should be intervening a little earlier on before we get, I hate this term, until someone hits bottom. What an awful term that is. I mean, you shouldn't have to ever get there before you can do this. The way that I sort of use the vernacular when I talk to people is I say, all right, you use a little bit, it's fun. Although in this context, when you say fun, it usually means sex. You then go on to fun with problems, all right? So you're having a good time, but some things are happening, it's not so good. And then of course you get like really serious problems with that. So there is a spectrum and people move back and forth, you know, along this way. Let me just say that there are also psychological and physical effects. And one of the reasons that is one of the key elements of people who really have some problems is that they need to be in a safe detox space. And so antidepressants, I mean, 50 to 60% of them are going to have an underlying psychiatric condition just as it's related to depleting dopamine. Also, there are some effects with serotonin as well. A person can have an arrhythmia, they can have a stroke with a single use, so it can have really pretty dire consequences for some people. But for most people, it requires a fair amount over time, neurocognitive impairment, and there's almost no part of the body that doesn't eventually get affected. You can get arrhythmias, people get really hyperstimulated. Part of detox is putting people into safe, quiet, dark environments so that they're not stimulated. People can become aggressive. Their self-confidence, all of a sudden, you know, the ugliest middle-aged man in the world all of a sudden feels like they're sexy. That's one of the reasons why there's disinhibition, you know, that happens. Now the other part of this is really important for whether you're doing a behavioral treatment or whether you're doing some kind of pharmacological trial, is that this particular drug, methamphetamine, which is highly potent and damaging to the brain, is one that requires a long time of recovery. This is a person who's normal control, basically single use, you see all of the red disappearing, and it takes, on average, 24 months. So you really have, and I would say that you really don't start seeing much recovery until about 4 months. So these matrix models, all these things are based upon 4 months of treatment. because that's when the sort of brain, I don't want to talk about recovery in the addiction world, but recovery of the brain starts to happen. And what you're doing with any intervention that you're doing is you're trying to give people a safe space so that their brain can begin to recover, all right? So whether you're giving them a sort of a nice quiet place or giving counseling, but one of the things that's really true in the addiction world is coming up with, if you take a look at rats, this is a rat experiment, but if you give them the choice between food and methamphetamine, they will use methamphetamine, they will starve themselves, and they will die. But if you give them a choice for social engagement, and this is where your all's role is, to engage them actively, they will choose an alternative pathway. And so I don't want to equate humans with rats, but the bottom line is, from an experimental perspective, you do not disengage with these folks, you engage further. And so there is no safe space. Let me say that again. There is no safe space. You must intervene, you must do it in a way that is meaningful, and it has to be on their terms. And so we don't say, go away, do your thing, and then come back and talk to us. We really need to find ways to engage, even with brief messages, and there are brief interventions that seem to be somewhat effective. Now, how does it relate to HIV? This is the US data from 2 different cohorts, but it somehow contributes to 16 to 32% of new infections in settings like this. And I would be surprised that no one's done that here in Southeast Asia, but I would not be surprised that in these evolving epidemics that we're not going to see this. Let me give you sort of a study that was done by Howie. This is a brilliant study. It's one of the finest methodologic studies. It's a micro-ecological study. It took it. And Ezra was sort of the champion to do this. 50 amphetamine-using MSM were given an app, and they recorded each day whether they had sex with or without condoms, and they used amphetamine. And what you can see is that at 25% of the days, they used amphetamines. 58% of these days where ATS was involved was also sex. So there's high concurrency between the two things happening. And I just learned yesterday that it happens more commonly on weekends. Shock. Sex occurred about 1 out of 5 of the days. 80% of them involved sex without condoms, so there's a fair amount of unprotected sex. And this was done before PrEP. So if I can say that you can do anything to intervene to keep them safe until you can do something about the recovery and the treatment, get them on PrEP. It's probably the single most important thing that you can do. And then, of course, where you see the convergence happening is that 346 of these days involved concurrent condomless sex with amphetamines, and you can see that it accounts for a lot of these days. And so the bottom line is that if you're in the midst of this concurrency, this pleasure concurrency, don't focus on getting them to stop, but focus on getting them under PrEP, all right? Because when the days that they're not using, they can hear that message, is a place when you can begin to intervene. The sad epithet of this entire thing is that during this 2-month observational study, the HIV incidence was 24%. I mean, it's a wide confidence interval. It is a tragic outcome, which means that you really have got to do something, and PrEP is the answer. Let's talk a little bit about the sexual ecology of HIV risk. We know that the infectivity is by the route of transmission. We know that there's a markedly higher elevated risk with receptive anal intercourse, bottoming, lower risk with tops. Well, one of the things that amphetamines do is they cause something called crystal dick. And tops become bottoms. And so it elevates the risk just as a consequence of that. The prevalence has probably actually achieved a level of, by the way, am I being insensitive by using these sorts of numbers?
It's a reality.
Well, I've got news for you. This is a reality check.
You being filmed.
I should have put my wig on. So, and then the prevalence in the population is probably unchangeable. But the one thing that, at least in Gabriel Rottello's sort of idea of the sexual ecology, is that one of the ways you can reduce risk is by affecting the contact rate or the number of sexual partners. And we certainly know that amphetamine increases disinhibition, as Carol mentioned, but it increases the number of sexual partners, new individuals who come into the social network, and I'll talk a little bit about that. And if you sort of want to think about how you might intervene, or even how risk is happening, you need to intervene where the risk is. In the old days of the HIV epidemic, we would go to bathhouses. We would go to places where the transmission happens. Well, guess what? Those places don't exist, and shutting them down doesn't work. We learned in the US that shutting these high-risk venues down, whether they were shooting galleries for people who inject drugs, or these bathhouses, was not an effective strategy. It disseminated things and you couldn't really intervene. But what ends up happening is that there are these circles of risk where people sort of move into and out of these particular settings, and they become at risk, they change their network, they go back into another network, and then they accelerate risk, and with these sort of expanding cycles of risk and people moving in and out of risk networks, so that maybe even people remotely might step into this for a weekend warrior. They come to New York City, for instance, or they come to Kuala Lumpur, go back to the kampung, and then there is actually a transmission that occurs. These tend to occur within sexual networks, and it is perpetuated, at least now, in the current milieu with your apps, your social networking apps. You can call them social networking, I call them sexual networking apps because that's primarily what they are, but it's potentially a place to intervene, and it's a place to actually find contact. Now, last night while we were at dinner, we did a little bit of an exercise. I went on the Grindr. And look what we find. So what can happen? So there's other things that happen. So first of all, there's shaming of the environment. People sort of cut people off, but they also say, this person's talking to me. No fat, chubby people, no old people. This person's a puffer. They've got a little snowman over here. They're chilling out. That's the vernacular for using stuff. And one of the things that you're going to see on every single one of them, they've been burning up this battery trying to find people because they're at 20% battery life. Let's take a look at this one. This one's a little bit more provocative. This one says he's a money boy. MB is money. Chem fun, part of the vernacular. Let's take a look at this one. This is Malay mix. Chem fun, bisexual. He's having sex with men and with women. Excuse my expression. Raw, FCK. All right, want slut. I mean, these are the sorts of things that are happening, out into the world that is actually accelerating risk. Here's a slammer. He's got a needle and syringe. All right, so we're going to do amphetamine by slamming here. He's a money boy. Networks. The network goes to Thailand. All right, so we can move it up here. High fun, slam fun. I mean, take a look at all of this. CF, fly. You may not want to be CF or chem fun. You can sort of fit it into a word. Attractive torso, right? All right. Threesomes. Let's make the more the fun. He can top, he can host. What will happen oftentimes is people of a more mature age like me might actually be the host, and you can all of a sudden bring in all of the young, attractive people that you possibly want. This person is on PrEP. All right, so you thank goodness for that. All right, so you see a little bit of that. And then, of course, this is flying high. You see your snowman that's going on here. So this is where it is. This is the new risk environment. What can we do about it? As I said before, the best data is for contingency management. And people say, what is contingency management? I call it its grandma's rules. There are negative and positive consequences. And so essentially the way that it may work, this is the American version, not the Malay version. But if you make up your bed this morning, you can have cookies and milk this afternoon. If you don't, I'm not taking anything away from you, you're just not getting that reward. You have to be very careful with these things because when the punishments are excessive to the reward, people actually use more drugs, all right? So these punitive things like putting people into, compulsory drug detention, these are the sorts of punishments that don't work. So your rate of reinforcement has got to be good, and it's got to be right. You got to figure out the right thing. If you happen to be, an MSM who is basically driving a big fancy car, what kind of rewards can you give them? A Gucci belt? So you have to think about the right kinds of reward for that sort of population. If they've lost their job, it's a different story. But if you're sort of that group, what can you do in those kinds of settings? What's really sort of emerged is it's starting to move into the technological world. It's starting to be used in many different populations, in rural and non-rural things. This is a place where there is the best data, but we have to figure out how to transform it into the sort of the new world of use. The problem, the really big problem with contingency management is there's not a government or an organization that really wants to fund it. Why would you give somebody money not to use drugs? Why would you give them money? This idea is unpalatable, even though it works. So it's the most effective thing that we have, but it's the most unpalatable because it means that you're giving something to somebody. My issue is I want something that works. I could care less about those sorts of things when the cost and the consequences of antiretroviral therapy and the medical consequences down the road are just too great. Where can you potentially use contingency management all the way from risk-taking to entering treatment to actually having them engage and then the reinforcement later on. It has a much more prolonged effect in general. Cognitive behavioral therapy is the other strategy. This matrix model, I'm not going to go into all the details. The problem with both of these sorts of things have got a modest effect. It's 16 weeks, so it's giving the brain some time to recover. It's very integrative. It has a bunch of things like behavioral therapy, mostly CBT, family education, 12-step drug testing so that you get some reinforcements from that. And it talks about sort of life skills and things like that. So it's actually quite good. It was developed not for MSM. It's not been sort of adapted to the virtual community, and it requires fairly reasonably well-trained counselors to do this work. It's 3 times a week. It is a lot of work, and so you better have some resources in order to do this. What I will say, for those of you who are interested, Steve Shoptaw and their group at UCLA has actually for the first time adapted it for the MSM context. This website, you can download the manual for counselors and for non-counselors for the patients. So this is a great resource. You're welcome to it. He provided access to this, and it's terrific. This is basically looking at why you need to contextualize it for MSM. This is the old matrix, this is for stimulant users who are not MSM, the gay bisexual adaptation, contingency management, or let's give them everything in the kitchen sink. Everything you got, let's throw it at them. And what you see is that in the short run, of course, giving them everything in the kitchen sink, they do the best. But you get pretty equal results with the contingency management and this MSM-centered strategy in terms of negative urines and the initial part. The problem is that over a period of time, people tachyphylax and they go back, they regress to the mean. So it may not be a full, kind of long-term outcome, and it may need to be redone again. What we do know is contingency management, at least for people who are, this is before PrEP, so this is post-exposure, non-occupational post-exposure prophylaxis in stimulant using MSM. By using contingency management, it increased the likelihood that they completed their post-exposure prophylaxis, that 28-day course, and their adherence to therapy. So you can use these kinds of rewards. You have to figure out the right rewards, and there are almost no punishments that occur from this. It started to move into the virtual world. This is Nancy Reback's work, theory-based text messaging. The bottom line is, and I can show you the data, but you can do automated messages, which are things that people like me think that's a good idea. But if you let people choose the terms that they want to use, and you can take a look at some of them, they're ones I would never use, but it's their messages. You can have all the slides, you don't have to take photographs. Then the bottom line is that they will actually do better with personalized messages. You see the amount of meth use in the last 30 days or sex on meth reduces if you have sort of personalized messages in the text messages. What do we have for treatment? This is mirtazapine. This was a really elegant study that was done by Grant Colfax. He took basically a small group of people, placebo-controlled. It's the doubly blessed trial of treatment. And what he really found is that urine drug testing results were much lower in terms of positive results in the mirtazapine group versus the placebo. The sexual risk-taking did not change as much. It actually was, for people who were receptive partners, bottoms, that risk did not change, but the topping did over time. What it did do is it decreased significantly the number of partners using ATS, the number of partners, no partners using ATS, and then episodes of condomless sex with discordant couples. So it did have a number of outcomes. The problem is that Collins and others just recently repeated this trial and could not replicate it. So I'm not sure that we're in real time with regard to that. Naltrexone had great hope. So what happens is that whenever you get euphoric, you use an opioid or whatever, it releases dopamine, and you have this endogenous opioid response. So you think you can actually stop the stimulus, that you can have an effect. This is oral naltrexone in the Swedish study, and you can see that the the use of amphetamines markedly decreased over time, more so in the treatment than the placebo. They tried to replicate that using a long-acting treatment. The adherence was actually the same between the two studies. And this is the study in Iceland, and it didn't show any effect. So once again, you do one study, you see a benefit, the next one you don't. Is it the right target population? The answer may be different. So what you see as a major difference is that the people in Iceland had more polysubstance users. 75% of them had an alcohol use disorder, 69% cannabis, cocaine, 26% sedative. So they were using everything in the kitchen sink. They also had higher rates of addiction severity, so maybe using people at a different level or introducing it to people at a different level may have a different outcome. And then the naltrexone group, because they had to get a shot in their butt every month, they dropped out more commonly from the study, and so you have differential sort of outcomes. I think if I can summarize that the best that we have out there is contingency management, but it's not palatable. Anything, even, it doesn't have to eliminate. This whole idea of abstinence or stopping drugs is not the right answer. You want to reduce it. The number, every day that you're not using meth means you're engaging in less risk. So from a transmission perspective, I will say that there are things that we can do in clinical care. We heard from Sungai, the director of Sungai Buloh, who's doing wonderful work in that area about sort of new models of care, differentiated care models. Take those resources that you save from doing that and really ask the patients. If you can screen, brief interventions actually work. I didn't show the data for this. And refer to treatment. Even if the treatment isn't effective, you actually get people to think about that. But the idea that clinicians are too afraid, they don't think the patients want to know about that, that is absolutely crazy. Every single study has shown that patients want you to engage with them. You just have to do it in a sensitive way. It's not like, you didn't use ATS, did you? Or tell me about, any alcohol or drugs that you might have used in the last month. So it's how you actually get at the question. And then also personalized texting may have an impact. I'm a physician, I like to prescribe things, what can we do? We've really got to engage the community. We cannot say that we've got this MSM community, but the ATS people somebody else has to deal with. That is not the answer. We are all one big community and we have to do this together, and it's not someone else's job, because when it's someone else's job, it's an excuse not to do something. We cannot let the other people take care of it because it is our duty. We heard about HERO. This is an integrated care model. That is the Cadillac, the Mercedes, or whatever you want. We have to start somewhere. We have to come up with alternatives. We have to build collaborations. We have to find partners to do this. We have to train our clinicians to ask. We have to get people out into the field. We have to be able to talk to them on social media at a time when they're willing to do that. And we need to be able to sort of engage our addiction treatment experts in an integrated way. And we need to reach our target population where they are, which is mostly going to be in the virtual space. Thank you very much.